Right, everybody. I think it's just tripped over to 9:32, so we will delighted to welcome again so many of you to London's Public Health Forum. It's great to see so many colleagues joining us for these, what I'm sure you're hopefully finding thus far, and will no doubt find again today, some really useful, informative and engaging discussions. My name is Julie Billett. I'm the Deputy Regional Director of Public Health for London. Unfortunately, Kevin, our usual chair for these forums, is otherwise engaged today giving evidence to the COVID inquiry. So I'm going to chair the forum today, and really delighted that we've got a really exciting agenda focusing on the role of the NHS in prevention, health equity and population health management. Just a few reminders, colleagues, about some housekeeping. Given that there are so many of us, if we could all try and remain on mute while other colleagues are speaking, please. Great if colleagues will turn their cameras on. It's always lovely on these events to be talking to a number of faces rather than talking into the void. Absolutely, there'll be chances to ask questions, pose those in the chat. Later on, we can maybe take some questions by colleagues raising their hands. But if I could perhaps just ask colleagues to avoid having sort of individual side conversations in the chat, because I think that can sometimes be a bit distracting for the speakers. We are recording today, so if you don't want to appear on camera in the recording, then I advise you just to post your questions in the chat. And there's some advice there about how you can turn off your live captions if you would like to. So if we can move on to the next slide, please, Abby. This today is just a reminder of the objectives for today. I'm not going to read these out. They were in the delegate pack that was circulated round. But as we said, we're delighted to welcome Caroline Clarke as the new regional director today. Relatively newly in post, so it's fantastic timing for us to have Caroline join us. More auspicious probably is the fact that today is the 75th anniversary of the NHS. Today is the actual birthday. I know there's a whole sort of month of celebration. 25 years to the day today that the NHS was formally launched. So great timing for us to be reflecting on the role of the NHS going forward in prevention, in tackling health inequalities. And improving population health outcomes, and an amazing institution that has just continued to adapt to all those kind of think about the evolving, changing pressures, changing demands, none perhaps more challenging than the recent couple of years that we've been through in terms of the COVID pandemic. So a great moment, I think, for us to come together as a public health family and celebrate and thank the NHS and reflect on its role in prevention. So thank you very much, colleagues. So I think with no further ado, I'm going to hand over to Caroline. As you'll see, Caroline's bio there. Really delighted to welcome Caroline to give a kind of keynote discussion today, or keynote presentation, and then there'll be a chance to ask a few questions of Caroline. Caroline's bio, as it says, she's many years of experience in very senior roles in organisations across the NHS, much of which has been spent in London and now stepping up into the regional director role for London. So it'd be great to hear about her priorities as she takes on that mantle, and any reflections from Caroline, particularly about the sort of focus today around improving public health and tackling inequalities. So if you're there, Caroline, and able to turn on your camera, I will pass the baton to you.
All right. Hello, Julie, and thanks for that introduction. And hello, everybody. Hopefully you can hear me. Julie, put your thumb up if you can hear me. You might even be able to see me. I am talking to you from Waterloo, from Wellington House, which is where NHS England is based, and very lovely it is too. So thank you very much for having me. Julie, I thought I'd talk about 10 minutes, maybe a little bit longer, and you can stop me talking if that's helpful. And we have a time for a bit of a chat. You're a very intimidating group to talk to. I'd just like you to know that. So I've tried to prepare. Some of you I have worked with before and are old friends, and some of you I've not met yet, but hope to. And the first thing to say, of course, is happy birthday. You can't talk to a group of people like this without acknowledging the kind of tough reality for everybody at the moment. But I hope that in the next 10 minutes, I can inject you with some of my optimism and enthusiasm and belief that actually the NHS has a good another 75 years in us. And if we concentrate on the right things, we can really, really do a fantastic job in the next couple of years. And that's because I think things are very different and going to be different. And I have been met with an immense amount of optimism and joy, actually, in the last few weeks since I've been doing this job. So I think we have the will between us to do things differently. We obviously had a workforce plan last week, which I welcome. There's lots of people that kind of sort of throw stones at things like that, but actually it's a good thing. Technology is our friend and data is our friend, and the renewed love of Michael Marmot is our friend. So I'll come back to that. So hopefully I can give you some of that optimism. I'll tell you a little bit about me and where I've come from, a bit about the London vision, which I hope you've all read, and then how we make that a reality. So very quickly, I'm an economist originally. I went to the LSE, and then I became an accountant because I didn't know what else to do and I needed a trade. My dad was a vicar, so public service is kind of through me, and I can remember being in a room with Theresa May, Simon Stevens, Jeremy Hunt, a bunch of other people, and everybody like had a vicar as a dad or a mum. I mean, it was just kind of weird, and it's like, well, there's a PhD in there somewhere. So I'm not particularly religious myself, but through COVID, I have understood much more the importance of faith and community, and I think have completely changed the way I think about actually just how we do business. And I think there's a relevance of that to kind of what you all do as public health professionals. I came to public health in the 1990s. I worked at Kensington, Chelsea and Westminster Health Authority with the HIV team. And that's where I first got to understand what it was that public health professionals did and why it was important. So that's where I started. Then I went to Camden and Islington Health Authority, and I worked on health improvement programmes with people like Ian Basnett and Sarah Scobie. So those of you that know them, you'll remember those, the good old days. And I learned about resource allocation, how important it was to think about how you spend money, where you spend money, how you can use it to influence health outcome. And in those very early days where we did everything on kind of really sort of tired old spreadsheets and didn't have very good kind of data or anything, actually that really set in my mind the importance of what public health professionals do and can bring to the party. So thank you to all those people for my early education. Most recently, I've worked at Royal Free. Those of you that know the Royal Free will know that it has an in-house public health team, and has always had an in-house public health team. And through all the cuts and the dark days, they were the people that kept us true, kept reminding us that every contact counts, that we served a population that had many different needs, but also some similarities. And we, over the last 5 years, we had a population health committee still there, which knits together the organisations in North London, and many of you probably been. I can see some of you here who I've met through the Population Health Committee's work, and I think that's really, really important. So at the end of my little talk, I'm going to ask you kind of for help, and one of the things I think that you can help us with is to describe to people that deliver care why population health matters so much, and why often when you analyse a population's health, you'll start in a different place to where institutions may have started, and I think that's a really important thing. I've just come back from America. I had 2 weeks there, partly for half term and partly a study tour of New York, and I had a couple of reflections that I just thought would be interesting to throw in at this point. Never have I heard Michael Marmot quoted so much, actually, as in New York City. And I don't know why, but virtually every person I met had had some kind of public health training. So that was one reflection. Second reflection, of course, when you walk around New York, it's quite obvious there's no welfare state and no safety net. So there is a really high incidence of physical and mental ill health on the streets. And it was really striking. And I took my 13-year-old with me, and she was quite shocked by that. So I came back with a renewed love of the NHS and a renewed determination to make sure that we got more than another 75 years in us. And also a love of urban health, right? London is the best city. I think New York is a pretty spectacular second, but London is just amazing, isn't it? There are so many good things about us in London. I'll come back to that. The other thing that I realised in New York, and again, people sort of slightly quoted this stuff at me, was the sort of the post-war the beverage sort of evils, the sort of, poor housing, poor education, poverty, unemployment, and of course ill health. And never has that context been more true, I don't think. So I'm really pleased, Julie, to be talking to you guys today of all days, because I think that the work that you do and the lights that you shine on where we need to focus are super important. So I thought that was probably worth sharing. I'm conscious of the time, so I won't dwell too much more on New York. But safe to say, if you get a chance to go and you haven't been recently, it's worth going. It's worth going for so many reasons, and I'm happy to discuss more at any point. And I was there when the Canadian wildfires were smoking, and I got stuck on Staten Island for 16 hours. And Staten Island is 500,000 people live on Staten Island. No one ever gets off the ferry. They sort of pop on the ferry, have a look at the Empire, the Statue of Liberty, but don't get off. So I got off and I spent a whole day with the people who lead the health system there, and it's almost like a perfectly formed ICS in some senses. And the thing that I learned from Staten Island actually was, whilst there may not be a safety net and a welfare state there, they have a set of really great relationships and trust, and an outlook on the population and what the population needs, and a way of working with community groups and faith groups that I thought we could only aspire to, actually. So I give you Staten Island. I went to the Montefiore health system as well, went to the Bronx, went all over, but I give you Staten Island as a thing about New York that you may not have considered before. So let me just talk a little bit about the London vision, if that's okay. So some of you will remember in 2019, the NHS and Public Health England, as was, and the GLA and the local authorities in London signed up to a vision for London to make London the healthiest global city and to make it the best city to receive health and care services in. Obviously, wind forward 4 years, the world is quite different, isn't it? Our context is different. So we're doing a piece of work to refresh post-COVID, post-economic downturn. Living in London now is much harder. Whilst we may be the economic powerhouse, actually that speaks volumes around as we recover, rich people will recover more quickly. So, I'm always really struck by the graph that Kevin puts up that shows the 12-year difference in healthy life expectancy between the sort of richest and poorest boroughs in London. And that's going to get worse as we recover, unless we're really, really intentional about which communities we help recover more quickly. And that's one of the areas that we need your help in, for sure. I still think that London is the best place in the world to live. I've tried to leave loads of times and I just can't. So when you look at, so when I went for this job, I was interviewed for this job in December and I was appointed about sort of a month and a half ago. So there's a big gap. But I remember going for the interview in December and I was kind of Googling kind of London. What do international benchmarking organisations say about London as a place to come, as a place to kind of be as a citizen? And actually, all those kind of organisations that do kind of sort of global city benchmarking, London's still up there, even post-Brexit, post-COVID. London has, some of the best universities in the world. It has the best arts, culture, sports. It's got pretty good green space. Transport's pretty good. Housing less good, and we can come on to that, but it's quite, so whenever you're thinking about London, how hard it is, actually as a global city, it's right up there, and that's sort of, that's really important thing for us to hang on to, and it's one of the things that gives me kind of real hope. So whilst I very much worry that the inequalities gap is going to widen, I have hope that we can actually do something about our capital city's health. So in terms of what am I going to prioritise, it's quite early, right? And I know that you should never tell a group of people like you what to do. So I've got all that in my mind as I talk to you. I'm embarking on a piece of work with the ICBs and with the kind of NHS leadership on where should we focus now, and we're gonna kind of be quite data focused and kind of have a look at in terms of kind of providing health and care that everybody can get to and providing better access, we will, I promise you, use some really good data that you will appreciate. And I would love to be able to come and talk to you when we've gathered our data and sort of test it out with you. So Julie, that's kind of one ask. But I've got 3 people whose healthcare that I really want to improve. So one is my daughter, who's 13, who told me about a month ago that she's vaped. I won't tell you what I said. Well, actually, I asked her what flavour, and then she told me raspberry bubblegum, and I went mad. So I sort of started off as a good liberal parent and then kind of undid it all quite quickly. But I want to make sure that for 13-year-olds and their parents and their carers, whoever's looking after them, that they have decent access to care and you know where to get it, and that they are taught in schools how to look after themselves. So she doesn't, you know, despite my job, she doesn't really know how to get healthcare, and none of her friends do. They are the workforce of the future. So any of you that have been involved in work on anchor institutions, on the NHS being a good employer, any of you that are interested in child and adolescent health, that stuff is super important, and I can't overemphasize that. So so that was thing number 1. I want to make healthcare better for my best friend who has a number of mental health conditions, is chaotic, and doesn't know how to access healthcare and always gets into trouble. So I want to make it better for him. And I also want to make it better for Helena, who is Polish and doesn't really speak that much English. And we met her a couple of years ago, and she's got all sorts of kind of bone problems, and has a job where she's on her feet, and she just can't get hold of her GP. And I just think if I could make it better for those 3 people, it would probably make it better for a whole heap more people. And you know, we've all got examples of that. So I don't think any of my 3 are particularly unusual, but I do have that in me to really want to make it better for them. And some of the things that we are thinking about are things that have been done in other cities. So an easier way of getting into primary and urgent care. So single front door, probably some digital solution in there somewhere, single phone number. Not everybody can use that. But of course, if you free up primary care for the more complex cases and for people who are digitally excluded, then, you know, good. So there's something for me around learning from other cities around single front door, much more emphasis on data and tech from me, actually, and then much more emphasis on the workforce, both how do we support colleagues in delivery organisations to retain their staff and make the NHS a brilliant place to come to work and a place where they can bring their whole selves to work. And I hope that you'll hear from Marie later on the work that our people committee is doing on both, you know, recruitment and retention, on, you know, that whole inclusion and EDI agenda, on the work of London and our race strategy thus. So Marie, I'm just going to give you a bit of a trail. I hope you're going to talk about that, because that stuff is so important for everybody, and the work that you guys have been leading in the people board is super important, and without our staff we're nothing, right? So, and without bringing I'm gay, and I didn't really come out at work till I was about 30, and I don't know what I was doing in my 20s, but I don't think I was very good, and I definitely wasn't bringing my whole self to work. So any of you that I met in my 20s, sorry, much better now. But I think that applies to everyone. We should all bring our whole selves to work, and I think most of you will know what I mean. So we're going to do, you will hear much more from us on tech. You'll hear much more from us on data and shared data and using data predictively. There is so much more technology around now than there was, which is why I think I have hope. And you'll hear much more from us on recruitment and retention. So I really do believe that we can do this. And I think there are three things that I would just close on then. One is other countries are ahead of where I think we should be in London, but we can get there. And I think the issue for us will just be one of scale. And secondly, we have the technology. We really do have the technology now. And most of what I want to do in London already exists. Each ICS that I've been visiting over the last kind of couple of months, and all the providers are doing bits of brilliant work. The question for me will be about adopt and scale. And then the third thing is there's so much goodwill around. People really, really want to make this work. So the leadership job is to corral that and focus us and prioritise us. So we're going to do that. So I need your help. I need you to help keep us focused on narrowing the inequality gap and on the vision for London. I need your help in connecting with other parts of the health and care system, particularly in local government and other parts of central government where some of you guys might work. And I need your help in reminding us that every interaction in the NHS is potentially a teachable interaction and something that can really count. So I'm going to stop talking, Julie. I've just realised what the time is. Thank you very much for listening to me. I'm very, very happy to have some kind of virtual chat now, if we can.
Brilliant. Thank you so much, Caroline. That's fantastic. And just what really shone for me was your sort of passion and energy and optimism about the future, which is fantastic, because sometimes we can end up focusing on some of the challenges, can't we? And it can feel quite overwhelming. So great to hear that that passion and enthusiasm. I just got a couple of questions. We've only got time for a couple probably, Caroline, but I just wanted to ask a bit about your leadership and how people would sort of see you as a leader. Can you just tell us a bit about, you know, I suppose leadership style is the best way of describing it, but, you know, how do you show up? What are the sort of features of the way in which you sort of show up as a leader, I guess, Caroline?
Well, it's very, you'd have to ask other people, really, wouldn't you? Because everything is, you know, I've got my own sort of spectacles and bias on that. I had a leaving do a couple of weeks ago in a pub. So the first thing is not very stuffy, straightforward, informal. I'm an extrovert. I really like people. I'm in this job because I like people, and it matters to me. So they had me doing vegetable impressions at my leaving do. That's probably about as much as you need to know, right? And but I think really the leadership job is twofold. It's providing kind of focus and direction and framework, but it's mainly allowing other people to shine and getting out of the way so other people can lead. Yeah. It's not, I used to play the bass guitar in a band, and I don't have lead singer syndrome particularly. You know, it's all about us as a team, and that's so important, isn't it? Because after you're gone, there'll be more people, and we're all a bit ephemeral. So I have a real strong sense of that.
Absolutely brilliant. Thanks, Caroline. I just wanted to sort of go a bit deeper into the issue of sort of, you mentioned kind of resource allocation, interestingly, as you know, you're part of your discovery of the world of public health, and I guess a challenge, you know, perennial challenge when we're talking about prevention, getting more upstream, is how do you achieve that system shift? How do you get more of the resource, the focus, the energy, people's time, and this, you know, system locus upstream and a focus on prevention when we've got such a tide of downstream demand? And I just wondered if you've got any reflections on that. I mean, it's, you know, it's the classic question, isn't it? But particularly from your experience at the Royal Free, where, as you say, it's got a really real strong commitment to population health, is invested in a public health capacity and expertise there. Just some thoughts about how, as a system, we might start to make some inroads into achieving that shift, Caroline.
Yeah, no, it's a really good and hard question. I always remember I worked in Camden, Islington, when we had health action zones. Do you remember those?
I do.
And in fact, we might have worked together on that. And I remember people saying this is really important, because I think they had a 7-year cycle, so it sort of transcended sort of electoral sensibilities. So there's something about the kind of the time. One of the leadership. I talked to Nigel Edwards before I took this job, who's the outgoing Nuffield Trust CEO, and Nigel said to me, one of the gifts you have as a leader is time. You can give people time, by which he meant you can prioritize over a longer time period. And I think that's really important on the prevention agenda. So we need to think in longer time periods as well as in the here and now. When I was at the Royal Free, I really thought that part of my job was to make sure that I'm going to say this, and it's going to, like, you'll all expect like magic to happen now, and it won't. But there's something about, you know, the outer boroughs in London are often less well resourced, and that's where we see people who are more deprived socioeconomically and all the other things that go with that. And so, and that impacts on the workforce and as well as the communities that we serve. And so I always felt like part of my job was to try and push the money out. It's really hard to do it, but there is something around how we get our leaders to think about that, and to think that is your moral responsibility. And actually, having gone to the Montefiore system recently and seen, it's kind of, you know, it's not quite what it was in the 2000s, but, you know, they're you know, they kind of sort of bought up housing developments and went right into schools, and, you know, that is kind of our job, right? So I think there's something about, don't think this is other people's jobs, this is our job. So I suppose the answer is, we've got to talk about it. People like me have to really raise it and be aware of it and give people permission to think about it. People need to have permission to shift resources. And then Julie, the CFO in me, thinks actually there's often, usually, always a clear economic case for doing this. It's just that it takes time. So as leadership communities, we need to give people that space and that headroom.
Great, thank you, Caroline. Really, really empowering, I think, to hear you say that with your background, experience, and role, I think. And I think I'm gonna, if that's okay, probably draw a line under our conversation now. Just mindful of time. Are you able to stay on, Caroline? If you could disappear,
no,
brilliant.
I'm good,
so we
can
can
another half
probably
an hour.
Pull you in for the kind of as part of the panel conversation, if that's okay. But thank you so much, brilliant presentation, very motivating and energizing, and we'll draw you into the conversation a bit later. So thanks very much for the moment.
Happy birthday. Thank you.
Happy birthday. So colleagues, we're going to move on to the panel session now, and I'm really delighted to say in addition to Caroline, we've got a fantastic panel of senior leaders from across the London system today. I'm going to just briefly introduce them. You can see their names there, but we've got Dr. Jonty Heaversedge, who's the Joint Medical Director and Chief Clinical Informatics Officer, so a real passion around data as well in Jonty's role, as well as a jobbing GP. So a fantastic combination of skills, experience and leadership roles there. We've got Dr. Gabriel, who is the chair of North East London Integrated Care System. She's a member of the London Health Board, chair of the London People Board, but also importantly, I think as well for today's discussion, Marie's role, chair of the NHS Race and Health Observatory. So Marie will be really interested to hear your perspectives around some of the things Caroline was mentioning. We're joined by Sarah Blow, who's the Chief Executive Officer for South West London Integrated Care System. Sarah has many years of experience working across the system in a variety of senior leadership roles, so it'd be great to get Sarah's perspective today. And finally, but by no means least, Will Huxter, who is currently the Director of Primary Care and Public Health Commissioning in the NHS London regional team. But similarly, Will has also sort of held a variety of roles across the system in London. I know Will from days of old in North Central London. So again, really welcome all four of you to the panel today, and really interested to hear your perspectives. I'm going to start off with just posing a question to each of you, if that's okay, and then we'll start to open it up to questions from colleagues. Do post your questions in the chat, colleagues, if you've got a burning question you'd really like to put to the panel. But Jonty, I'm going to come to you first, and I just wanted to sort of follow up from a bit of what Caroline was saying, really, and ask about how important public health has been sort of to you in your career, in your current role, in terms of providing sort of that leadership, public health advice, and possibly challenge to some of your thinking and that of your kind of leadership cadre in South East London. And any sort of reflections on how you think that role could be even more sort of strengthened going forwards, I guess.
Thanks, Julie, and hi everyone. I hope you can hear me. I'm dialing in from a Methodist church where we're having one of our team development days. One of the things that I think I've really enjoyed doing is starting to kind of experience some of the communities that we serve in South East London. I mean, that's a huge question, isn't it? I was lucky enough actually to be involved in clinical commissioning groups, and we had such a strong relationship at borough level early on with public health colleagues. It was always the most important part of the meeting. So the public health reports, the conversations that we had about our population, to the extent that I think now, even more than when I was a GP, and of course just as a GP, I feel very connected to my community, but I started to really understand how data can drive some of the insights that we need so that we can change the way in which we work. To the extent it is now kind of in my bones, I would say. I mean, I don't look at anything without thinking about the people who are receiving care, the experience they're having, and the impact that that's having. I suppose the other thing that was really important from my point of view is that public health helped to open my eyes to the very limited contribution we actually make to people's health outcomes, to really understand the wider determinants. And I guess that underpins the commitments we're making as integrated care systems to join forces to try to address some of those, because in reality, we just aren't going to be able to do that in isolation in my practice or more widely in the system. I do think that the experience of transition into integrated care systems and boards has been that a lot of the opportunity here sits within our places. And there's a really rich conversation at the moment about how we ensure that our places are empowered effectively to be able to contribute to local communities and understand their needs. I think at board level across the whole system, the insight that we get, and as a clinician, the contribution that data makes, that Caroline has really helpfully amplified, is going to be key. I'm not sure we're there yet. I'm a strong advocate for starting to link up our data and have deeper insight into our populations and become much more proactive and targeted in the approaches we take. That's something, again, we learned from the pandemic. We learned that through some of the vaccine hesitancy work that we did. The first time we'd had real-time data about our local populations, and we could work with public health colleagues to understand, and with local communities to understand how we would address those in a more targeted way. I will stop because I know there's I mean, but there's so much more that we could talk about in terms of the importance of public health.
Great, thanks, Jonty. Yeah, some great example. You know, as you rightly said, you know, I think the pandemic has given us that fantastic insight into the possibility and the power of data as we use that in the vaccine programme, and how do we ensure that we take that sort of systematic population health approach using the assets of data that we have in the system, which are almost second to none, I guess, in the NHS and the public health system that we have here versus other countries and systems. Marie, I'm going to come to you next, if I may. And Caroline sort of gave you a bit of a platform, didn't she, for talking about lots of the work that you're involved in. But obviously, the public health community is, you know, it's in our veins, essentially, the focus on health inequalities and health equity. And definitely in more recent times, there's been a much greater recognition of and focus on racism as a determinant of health inequalities in London and indeed across the country. And a real commitment coming through from London leaders to being proactively anti-racist as organisations and as health systems. And I just wondered if you could tell us a bit about the work that's being taken forward in London and your perspective on how we really drive that agenda forward, Marie, in London.
Thank you. So yes, I think I'll do this with my hat on as the Sadiq's champion for tackling structural racism, and I think that, you know, there's a really good framework that started with the London Health and Equality Strategy, but also with Building Fairer Cities, that sort of Kevin has led us in terms of thinking about how we can tackle structural racism. So the first is that recognition, and I think the London DPHs have got together and actually made a commitment to anti-racism too post-pandemic. But, you know, to recognise that structural racism is a determinant of the determinants of health inequalities. I think the second thing is actually about creating anti-racist organisations that therefore are actively trying to improve race equity. And I worked with the chief executives and chairs of the London Integrated Care Systems, who without hesitation agreed a joint statement on being anti-racist organisations and partnerships, because remember, they represent rather large partnerships. And quite rightly, they were pushing back and saying, but we need to make this real for our populations, because each of our populations are different. So in North East London, we have a population of over 70% that's Black and minority ethnic. And I think the other things that's really important is we're building an anti-racist practice learning hub, because there's lots that we do and there's lots that we have to share. And I think one of the other things that I can't forget about is my role as co-chair of the London People Board, and actually improving equity and the role of employment in doing that is core. So we have a whole London workforce race equality strategy that has everything from devising recruitment to increasing representation and holding people and embedding accountability. So I know we can't talk for long, but there's a whole range of work there, and actually Kevin is a member of that board. And I think what's really important is actually making sure that public health is embedded in all that we do. Thank you. Can't hear you, Julie.
Great sentence to end on there, Marie, because I think that would be certainly the public health community's ambition is to embed ourselves everywhere we can, because we see a role for public health in all those different spaces and places and levels of the system. Just sort of building on that, Sarah, I'm going to come to you. You know, you're there as South West London Chief Executive, and I'm just really interested in your kind of approach in South West London, or drawing on your experiences in other places throughout your career, about just practically working with public health, and with particularly sort of public health leaders in local government, any public health consultants and specialists that might sit within the ICS, but thinking about that in a very sort of practical way, and whether you've got any sort of reflections, Sarah, I guess, on how public health can really make the greatest contribution to the ICS. You've got your 4 overarching aims and missions. I would say public health has a role across all 4 of those overarching aims. How are you making the best of and building those relationships with public health teams, and making sure that they are really able to exert their influence and support you to deliver your mission as an ICS in South West London, Sarah?
Thank you. First of all, I have got to say my happy birthday to the NHS, and thank you to all our staff, but also our staff from the past. And I'm going to mention the other 75th this year, which is the Windrush generation, and the great support that they've given to the NHS over many years, and their families. And we've had some celebrations on that, as well as the NHS 75. So I just wanted to start with that. So you're right about the new 4 key roles of an ICS, which include health inequalities, health outcomes, and improving outcomes. And I do think that is a shift from where we have been, because the NHS historically has been a treatment centre, hasn't it, rather than a health improvement centre. And I do think that that is helping us with our focus on the right things. I can remember many years ago when public health sat in the NHS, and when we had the changes and public health directors moved over to local authorities, there was really good reasoning for that, because wider determinants of health makes absolute sense. But somehow or other, we kind of lost the link, didn't we, a little bit? I felt a real loss. You know, I was a chief executive at the time, and I felt a real loss of that kind of knowledge and understanding and working together in a way that really made sense. And over the years, we've tried to put that back informally in a way that makes sense for us. But I think now is the time, guys, for us to really take the opportunity that we now have around ICSs with their core purposes, to really put it back together in a more formalised way, and to make sure that we get all the benefits of working with local authorities and the wider determinants, as well as kind of the NHS focus on prevention improvement, which kind of we're trying to move towards. So opportunity there. Locally, we have done a lot of work on working with, I've got 6 local authorities in South West London, and the 6 public health directors work really closely together, and we've been working together. And I've also have a role in the ICS, which we jointly employ. So I have a role who is a public health director who works jointly for us in the ICB with the directors of public health across South West London, to help us to pull together the information, the support, and the work that we do together. And that's helped us with developing our 5-year plan. It's helped us on the ground in local authorities, because we do a lot of work on the ground as well as at South West London level, so right down to kind of individual patient and citizen level. So a good example of that would be in Kingston and Richmond, the Winter Warm, which is where we're working with local authorities and public health. We looked at homes where energy efficiency was terrible, and we also cross-referenced that with risk stratification on patients, and said, actually, there's a load of people here that need some help. And we supported, the local authority supported with things like putting in insulation. We supported by using social prescribing to identify the right people to direct to services. And, you know, so there's small, they sound quite small, but those are significant changes in the way we work. So I think we can do it at a small scale. But I also think, sort of talking London, we in London, didn't we, a few years ago, worked with the mayor to do the smoking ban across London early. And those are the kind of really big things we can do together as well. So I think the NHS and public health working together has real opportunity, and we can do great things, and we just have to make it work.
Terrific, thanks, Sarah, and great to hear some of those really concrete examples, I think, as ways in which you're, working very practically with public health, but also, to sort of Jonty's point about the role of systems working together on some of those wider determinants, which is so important if we're going to actually improve population health outcomes. So thank you. Will, I'm going to come to you with a bit of a question about sort of immediate sort of priorities and pressures in the NHS. Obviously, we're still in that very sort of post-pandemic phase with a real laser-like focus on recovery, of elective care, of things like recovering prevention programs, screening and immunisations, for example. Can you just tell a bit about sort of what and how the public health family is sort of contributing and supporting on those more immediate kind of priorities? I think often it's easy to think about public health as having a more medium, longer term role in terms of that orientation to prevention. But what about some of those more immediate priorities that the NHS is grappling with at the moment?
Thanks, Julian. We've talked a lot already in this session about London and what London has as assets and strengths. And I think one of the great things this forum represents and is part of is that broader interaction and connection up of public health and the broader NHS at all sorts of levels, from borough level upwards. We have the assets within the GLA, we have OHID, we have obviously our colleagues in UKHSA, as well as within NHS England. So I think it's an incredible wealth of public health expertise. You're absolutely right, of course. There's lots of demands and pressures on the NHS at the moment. Access in primary care, access, waiting times for both urgent emergency care as well as for elective care, some of the diagnostic waits. And I think if I start with outbreaks, I think one of the things that's been really fantastic where we've had outbreaks of particular conditions and vaccine preventable disease, one of the challenges that we face is whether it's in mpox, whether it's in work we've been doing around polio, whether it's work we've been doing around MMR, it's that local connection, it's the knowledge of the local communities, it's understanding the best way of reaching them, which public health expertise really brings. And I think that's a level of understanding, knowledge and evidence about what we can do that's really important. I've particularly benefited from that focus on evidence and data in terms of what we do and approaches we take to reaching those different communities. I think if we look at the immediate and the longer term connect up when you think about what we can do in the prevention space, don't they? So one of my concerns I mentioned vaccination uptake, but if you look at screening, we still have situations where people are having cancers not detected because they're not coming forward for screening. And I think about the sort of longer term capacity, but also trust and faith of communities in services and what they can offer. It's fundamental to people's lives. And I think that broader focus on individual and community well-being, which public health really represents, is a fundamental part of what we need to do. So I think the immediate and the longer term definitely join up. Thanks, Julie. Thanks,
Will. Really helpful. I'm going to perhaps come to anyone who wants to contribute around that sort of community-led, asset-based approaches. I think a real sort of focus and strength of public health, as colleagues have mentioned, is that intentional focus on working deeply with our communities to understand challenges, barriers, co-design services. And I'd be really interested in colleagues if you've got any particular great examples or best practice that you'd really like to share from your local systems or experience, or any sort of reflections on that. But Jonty, I'm just going to come to you with a bit of a techie question about AI that was posted in the chat. I guess just, I think you were sort of signalling the power of data, the opportunities that we have going forwards in that space. And I just wondered if you've got any sort of reflections on how well the system is as yet sort of set up, or really thinking about very proactively the huge opportunities that sit in that sort of technological and data advanced space around AI and ability to kind of make greater efficiencies and best use of the workforce that we've got, or even replace the workforce in some way, shape or form. So any reflections on that sort of a frontier of technology and data, I guess.
Okay, right. So look, the bottom line is that the opportunities are huge, and you've just really helpfully described some of them. If I'm honest, I'm probably not hugely concerned about at the moment, certainly about replacing the workforce, but I do think there are real opportunities in terms of how we work together very differently. My sense is that actually the first thing we need to start doing across London, and Caroline will have this as a clear priority, is we have to start systematically using data. AI is really exciting, and of course the way in which we can learn from that data and we can start to automate that learning process, and we can develop deeper insights than we've ever been able to develop before. That is clearly a fantastic opportunity, but there are a whole shed loads of opportunities that we are not currently identifying in relation to the data that we have, that we either don't look at or we don't translate from insight into application in the work that we do. So I think actually, whilst I'm very excited about the prospect of AI, I'm more excited at the moment about our opportunity to start to link up data across London, and there's been some really great progress through the development of a secure data environment to support research and intelligence, but actually more broadly speaking, to think about how we create the kind of data services that we need to support population health management, which is very dear to my heart, and how we use that data to better identify, as I mentioned earlier, for example, in the pandemic, better identify communities where we would want to really amplify our efforts and our resource into trying to support them more effectively. Final bit, I guess, is that the real challenge then is how you take that data and insight into interactions that we have with individuals, because whilst it's incredibly helpful, and we've learned from public health the value of looking at population level at that data, when you can actually use the insights to make a different decision with somebody about their care, you are really then starting to shift the dial on outcomes. So loads of opportunities, but the basic building blocks of kind of data connectivity we've got to start to focus on if we want to achieve that.
Fantastic, thanks, Jonty. So yeah, making better providing the architecture and the infrastructure and making good use of what we've got before we necessarily are rushing to think about that next frontier. Just come back to any member of the panel if at that point about sort of working very deeply and thoughtfully with our communities and that sort of asset-based approach, thinking about our communities as our assets. Anyone want to make any sort of offer any reflections around that or examples from local practice? Sarah, let's come to you.
I'll give you an example. So we've been doing a lot of work with and I'll get the name right on this. It's the local community network in community empower network in Wandsworth, and we had, so a good example, 5 practices in Battersea where they had 50% of the patients that they were looking at had very, very high comorbidities, but also were from Black and minority ethnic background, and they weren't accessing services, so they weren't actually coming in to see the GP, and I think it was around 10% of them hadn't accessed a GP in sort of 5 years or something. And by working with the community engagement network, they went out and talked to those people and said, how do you want to access services? How do you want to be, engaging with your GP? And the GP practice set up a load of kind of meetings in the community, went out and talked to people, went and saw them in the community rather than in the practice, used the community engagement network as a facilitator really for those discussions, and supported them in engaging and trusting, because there is a trust issue, those doctors in what they were doing, and they've seen a significant increase in the engagement with their general practice in those communities. Those kind of things are really, really important. I mean, we're trying to actually release some funding in South West London to support local community voluntary sector organisations to help us with some of our big priorities around things like workforce, around things like how do we engage with the populations that we don't usually reach in a way that makes sense. So I think there's huge opportunity there, and they are unsung heroes, aren't they, really, of what we need to do going forwards, because they are a huge resource for us.
Brilliant, thank you, Sarah. Great example. Marie, let's come to you as well.
I think we've all got examples of how we're working together at place, and I think one of the really important things is sustained funding, and we've committed to delegating 20 million funding over the next 3 years to really focus on building community assets to tackle locally defined health inequalities, and I think that's really important. And it's seen some really interesting work. So, for example, our primary care networks are now working with West Ham United Football Club to tackle knife crime. And so that approach of violence being a public health issue has really helped us to rethink how we approach that and how we can approach that with communities, and with actually people get communities trust, because trust is a really big issue in diverse communities.
Thanks, Marie. Yeah, absolutely. We hear that, you know, time and time again. It's that trust and confidence, isn't it, is critical to repairing some of those relationships with communities and engaging and working alongside them. So thank you for that. There's a couple of sort of questions in the chat about sort of, I guess, what you describe as that making every contact count approach, really. How do we ensure the whole of our health and care workforce is sort of upskilled, confident, competent to engage with through their everyday interactions and encounters with patients and carers, to have that focus on prevention and supporting people to improve their health and well-being, rather than focusing on all, you know, that more kind of immediate response to their presenting need, as it were. So just a thought, or just any reflections from colleagues about, you know, where do you think we're at in that? How do we build that sort of workforce that has that orientation, that focus, and the skills necessary to really embed that making every contact count focus on well-being and prevention? Jonty?
One of those people who often puts my hands up and then slightly regrets it, but I think there's a huge there's clearly a huge amount that we can do in terms of training and so on. I suppose I really want to try to shift the emphasis slightly away from that more opportunistic approach to being much more systematic about trying to identify people. So I think very often every contact counts reflect a kind of like, if you have an opportunity, then let's use it. But we know that very often people are falling through the gaps because the opportunities are not identified consistently. So from my point of view, one of the conversations that we've been having a lot, so we've got a slogan about making the right thing to do, the easy thing to do in primary care. And that is all about giving people the tools that they need and the information about the people that we need to much more systematically engage with. So in a sense, it's not relying on a sort of opportunistic approach to, I don't know, a motivational intervention when you see someone behaviourally. It's how do we much more effectively help people to identify those people that they should go and have that conversation with, and then give them the skills to be able to do that. In primary care, we've done that obviously in a more kind of clinical setting to say, who are those people on our diabetic registers who haven't had their foot checks? How can we much more consistently identify those people? Who are those people who haven't had their blood pressure checked? So suppose it is making every contact count, but can we actually do that in a data-driven, systematic way, which is one of the things I've learned through public health, if I'm being completely honest, because it's not something that automatically comes to clinical colleagues necessarily. So I suppose I would try to focus on that element of it, if it's helpful.
Yeah, really helpful insights, Jonty. Thank you. Can only make the contacts count, can't we, if we're actually reaching and engaging with colleagues, with our population and patients. Will, come to you.
I absolutely agree with Jonty's point about the data and trying to make things systematic. I suppose one of my reflections from the vaccination programme around COVID was we put a lot of time and investment and focus looking at making every contact count, and I think it was variably successful. And I think it's about having both the staff stroke volunteers and the people coming forward, it being the right time for them. And I think if we have a one-off intervention at a particular time when you're coming along and having something, that doesn't have that resonance into the longer term. So I think it is there've been a number of points in the chat about values and approaches and how we support the workforce more generally. I think it does need to be one of those core things for all members of staff, clinical and non-clinical, working in the NHS, to be thinking about this, but also having a properly systematic approach, very much as Jonty described.
Yeah, thanks, Will. And Jonty, hand back up. Do you want to come back in?
Yeah, just one other thing that, sorry, sprung into my head when we were speaking is I do think that we need to move away from a medical model around this and assuming that it is often clinicians. And of course, I immediately go into that because I am a clinician, to that way of thinking. But there are loads of examples. So we were looking at the example from Westminster recently. There are examples in all of our places already, in Lambeth, working with Portuguese communities. Everyone will have examples of this. Who are those people who are trusted in our communities, who, having helped to identify those people who are currently disadvantaged, can go and engage them and have those conversations? And I don't think it's always the people we think it is. Sorry, just to add.
Yeah, no, that's great, thank you. Colleagues, I'm conscious of time and I'm going to just pose one final question to each of you. I'll come round to you and ask for perhaps really short, sharp 30-second answer. Caroline, you too, I'm going to come to you. And this is just about looking back on the pandemic. What's the one lesson from the pandemic that you've personally taken into your current and sort of future practice? The thing that you say, actually, I'm not going to revert back to how things were previously. I'm really going to hang on to that and ensure that that affects the way I'm a leader, or where I practice my, my management, whatever it might be. What's the one thing that you would say you're really hanging on to and building into your practice and your leadership going forward? So I'm going to pick on people as we go round. Marie, I'm going to come to you first.
Great, thank you. So I think for me, what the pandemic taught me was about the importance of dismantling barriers to partnerships, including removing layers of unneeded governance and duplication, but also really having a brave appetite for risk, so that we truly do create a sort of, I suppose, better solutions with and for our local communities, particularly those who experience additional disadvantage and, of course, me specifically, racism. And that's a real commitment to joint endeavour across, I think. Thank you.
Brilliant. Thanks, Marie. Sarah, let's come to you next.
Well, apart from the fact that we can almost do anything, can't we, with all that kind of energy and power behind us, that was the first. But the main learning, I think, for me was when we did the vaccines, around how we engage with communities, and we were kind of telling people what they needed, and they weren't listening, were they? That's because we weren't listening to them. So I think there is something about how we listen and reflect on what we do that I think was a huge learning during the pandemic, and something that we all need to take away.
Terrific, thanks, Sarah. Will, let's come to you next.
I think for me, what the pandemic really powerfully showed was just the extent and starkness of the level of health inequality. And back to that point about Sarah was just making about listening to communities, really needing to understand that and actively work to tackle that if we're going to reach our communities in an effective way. So I think from a values, from a championing, from a how I talk as a leader, having health inequalities at the forefront is absolutely fundamental.
Brilliant, thank you, Will. Jonty?
So I've reflected on this a fair bit over the last few months. I'm a bit of a control freak, turns out. And I think one of the things that I have learned is the importance of letting go. So there was a lot of rules that were sort of thrown out. That unleashed huge potential in our communities, and really allowed us to shift the dial. And I suppose what that means to me as a leader is to be increasingly clear about the what, but not on the how. So what we did have was clarity over what we needed to do, but not how we needed to do it. And that freed people up significantly. Yeah. So for me, there's something about letting go and unleashing and giving the right level of permission. Yeah.
Brilliant, thank you. And final word to you, Caroline.
Well, you lot it's awful following you. Like, just that was, thank you for that. I'm really glad that I stayed for that panel conversation. Thank you. I think for me, the lesson, all the above, and I wanted to say something about education in school. So I mentioned it when I was talking earlier. The kids in school, so 2/3 of kids now in school are going to have jobs that don't yet exist. So firstly, they're the workforce of the future, and none of us can even imagine what it's going to be. So I think part of our job is to help the next set of leaders imagine what, how the world will be. And secondly, this point about trust and relationship, it starts in education. So getting those kids ready to use the health service, use care service, understand what public health professionals do. They're the workforce and the populations that we serve. So I'm personally going to spend much more time in schools, and I wish we'd kept them open, actually. I wish we'd done more on that, but obviously that's, for another conversation. Thank you very much for having me.
Brilliant. Well, thank you, colleagues. Some fantastic insights there. I think we could sort of etch those thoughts into tablets of stone and take them into the future, couldn't we? And that would be a really good guide for some fantastic practice and leadership going forward. Thank you for those quick reflections. So just sorry we've run over time just by a minute or so. Just really interesting conversation. I get carried away with listening to you all. But huge thanks to Caroline for joining us today and for your keynote speech. Great that you were able to join us, Caroline. Similarly, thank you to Jonty, Sarah, Marie and Will for all your contributions and insights. It's been really, really helpful and really interesting, and a great space to kind of hear those reflections and hopefully to sort of inspire, motivate and continue to build the kind of collaborations and joint working with the public health family in London going forward. So thank you very much, everybody. We're going to move now into the Public Health Faculty London meeting. So colleagues who want to stay on for that, please do. But colleagues who've got other things to get to, thank you so much and have a great day. Thanks very much.